Following on from the emergency management of TTP, all patients with TTP are monitored as an outpatient to try and prevent relapse of their TTP. And this schema here shows us what is happening in a typical TTP patient's course. So in the left-hand side, we can see at time point 0, patients have a low ADAMTS13 shown in red and a low platelet count shown in blue. But after the introduction of the 4 main treatments, rituximab, steroids, plasma exchange, and caplacizumab, we'd expect firstly a brisk improvement in the platelet count, and following on from this, a normalization of the ADAMTS13 activity. All patients are recommended to have monitoring of both their platelet count and ADAMTS13, and around half of our patients will have a subclinical fall in their ADAMTS13. This is really important, as if we identify the fall in the ADAMTS13 before the patient develops clinical symptoms, then it's possible for us to treat these patients electively, typically with anti-CD20 therapy such as rituximab, and in that process we can prevent the patient from having another acute episode of TTP and the resulting morbidity and mortality that can be associated with this. So just to end on here, so England has now become the first nationally commissioned TTP service across the world, and here this figure shows us the 9 different regional TTP specialist centres over 11 different sites, and your local hospital should be discussing suspected TTP cases with your local regional TTP specialist centre. So just to reiterate, that should be being considered in patients with MAHA and thrombocytopenia to consider a diagnosis of TTP. If the laboratory features are suggestive of this, then we would recommend urgent discussion with your local haematology team and an urgent blood film to try and decide whether the patient does have TTP.